Hello, everyone. Welcome to today's live broadcast, Hand Up, Train and Retain Your Medical Support Staff. We are pleased to bring you this webcast presented by Medical Economics, sponsored by the National Health Career Association and the Verdin Group. We have a few important announcements before we begin today. This webcast is designed to be interactive. We encourage you to ask questions during the event, and you can submit your questions by typing them into the Q&A box, which can be found at the bottom of your screen. You can enlarge the slide window by clicking on the small square icon in the upper right-hand corner of the slide window, or by hovering your mouse over the lower right-hand corner and dragging that window to the desired size. The slides will advance automatically during the event, so you don't need to worry about that. If you have any technical problems viewing or hearing this presentation, please click on the question mark help widget at the bottom of your presentation window. Again, I just want to remind our audience how to submit questions. We do want this to be interactive. So yet again, you can submit those by typing them into the Q&A box, which can be found on the right-hand side of the presentation window. We'll try to answer as many questions as we can throughout the presentation today. Any questions that we're not able to get to, we will respond to you directly after this webinar. Again, thanks so much for joining us today. My name is Kayla Steffen, and I'm the Business Development Manager at NHA, the National Health Career Association. Just a little bit more background on my company, NHA. We are the largest allied health certification agency in the nation, offering 8 fully accredited national certification exams for both clinical and administrative professionals such as medical assistants, phlebotomy, EKG, electronic health records, patient care technician, pharmacy technician, billing and coding specialists, and administrative assistants. As a provider of certification exams for over 30 years, we've really listened to the market and have evolved to provide learning resources to help fill industry demand. Resources such as soft skills training for healthcare professionals, and we do that via virtual simulation. And we have motivational interviewing and patient engagement training that includes virtual simulation, and training for those practices that are operating in or getting ready to transition to a patient-centered care model, which that's really what leads us here today. We work really closely with educational institutions and healthcare employers across the country to certify staff and train staff for various career laddering opportunities. I'm excited to present alongside Suzanne Madden of the Verdin Group today. And at this point, I will turn it over to Suzanne for an introduction and a background on the Verdin Group. Suzanne?
Thanks so much, Kayla. What a pleasure to be here today. And precisely that, we are here to really discuss how to get a leg up in terms of training and retaining your staff, and never more important than now, frankly, as we are experiencing COVID-19. My name is Suzanne Madden. As Kayla mentioned, I'm the CEO of the Verdin Group. We are a practice management consulting firm, primarily focused on working directly with physicians, often in independent practices. And our client size really runs the gamut from solo practitioners, all the way to multi-location, multiple partner practices. So I'm excited today to be able to sort of speak to this audience and really talk about, what does it take to create a really great team that's going to support you in all of the work that you do, and really make sure that you can retain them, grow them, educate them, and in return get a nice return on that investment. So today's agenda, we're really going to be looking at physician burnout, because it's really all about physician burnout right now. So understanding what drives it and ways to prevent it, particularly in primary care. So we're seeing such high volume, just being able to take care of the patient load that you have. If you're not well supported with a great team, that really can add to physician burnout. So we'll talk a little bit about that. Then we're going to discuss leverage medical support staff to significantly improve efficiency in operations, not just a little bit. We want to significantly, improve the efficiency that you have at your practice, and talk about ways in which your staff can really support all of the things that you do as a clinician. Then we're going to talk a little bit about understanding the benefits of implementing a medical support staff training program. How do you go about putting a training program in place? What should you be really looking to do, and what could you sort of expect to be appropriate outcomes? And then using career ladders, as we call them, as a key strategy for that staff retention and career growth, particularly around MAs and some of your clinical support staff. So physician burnout, if you're a physician, you can identify with this so readily. I don't need to sort of read the percentages to you. But the key takeaways here really are, while physician burnout may be down a little bit, right, down from 33 in 2016 and down from 48.5% in 2012, what we're finding is that physicians are really at full capacity or they're overextended, right? There's just too much to do, too little time to do it. And frankly, with COVID, you really had to shift your workflows, on a dime, right? And so what we're finding is that, even those physicians that were at full capacity, but that were able to sort of work within some good, strong, structured workflows, really all sort of bets were off once COVID-19 came into play. And now we're finding that as people sort of get back to some sort of normality, and I say that obviously as a caveat, but as we sort of get back to just being able to sort of see patients again in our offices, maybe a little less telemedicine, a little bit more in person, we're finding now that physicians are having to juggle to both, right? And that the needs of patients have changed quite a bit. 78% of physicians report that sometimes, often, or always they're experiencing feelings of burnout. That doesn't make a happy workplace, right? That's not a happy doctor. And that 23% of physician time is spent on non-clinical paperwork. And that's where we really want to sort of underscore this idea that if you had more time in your day to do what only you can do, and the rest is well supported by a well-trained staff, then obviously that is able to give you some time back to not feel so overextended in all of the other things that you have to do. So Medical Economics just ran this really nice report. So if you haven't had a chance to check this out yet, definitely look at the Medical Economics 2020 Physician Burnout Wellness Survey. It was just published, I think, in September. So as current as you can get it. But when I was reading this, I was really sort of concerned to see that the feelings of burnout are really being so heavily driven by this idea of paperwork and payer and government regulations. In other words, more to do that is less about clinical care. And that's really concerning, right? Because that is not what you went to med school for. It's not why you chose to be a doctor. You didn't say, great, I'm going to spend at least a third of my time, filling out paperwork and trying to do those things. So I was kind of alarmed to see, 31% are really saying that that's a key driver of physician burnout, right? Then poor work-life balance and working too many hours. Well, of course, the more burdens you have and the more paperwork you have to do, and the less that you're sort of just involved in the patient and then going home, then obviously that is going to eat into your personal time. And, you have long schedules, long days as it is. And then, of course, the COVID-19 pandemic. So fully 12% of what is contributing to the feelings of burnout are related to COVID-19. We got a little bit of ease, I think, the last couple of months, but now we're about to go into winter. And how that plays out and where that plays out, it remains to be seen. Of course, anybody that is listening to the news, I think we reported the most amount of cases of COVID so far in a day, yesterday or the day before, at 100,000 cases in the country. So, we're really still going through this pandemic and really feeling the effects of it. EHRs, electronic health records, 12%. That's always been a problem. Since the advent of electronic medical records, it's been an issue, right? Because it may be a tool, yes, but it's also something that slows you down, right? Being able to, make some shorthand notes and jot things down on paper is much more efficient in terms of speed, obviously, than keying things into an EHR. So that's always been a problem. There's no remedy in sight for that. I don't know that we can help you a lot with changing EHRs, but we can certainly discuss how you can utilize your support staff to make better use of the EHR so that you're not having to spend all of the time, in the EHR, having to do all of these things yourself. Lack of autonomy and career control is a big issue. 7% say they don't feel burned out at all. That's great, but it's only 7%. I mean, it's such a small amount, right? And, again, overwhelmed by patient needs and non-adherent patients, really speaks to that patient load. It becomes sort of exponentially critical when you have a really high patient load, right? Because that one patient that needs that extra 10 or 15 minutes of your time in a day or in a shift or in a session is what is really going to sink you, right, and put you behind for the rest of the day. So we can totally understand and see and hear very clearly from physicians that all of these things combined, really add up to 71% saying that, you feel burned out right now. So a big issue, and one that actually can be tackled. In physicians' own voices, though, what we medical economics ask, what do you believe is the solution to physician burnout? I'm going to read these to you because I think they're really powerful. I don't know. I just, every single day, I go to the office and I have people every single day that I dread seeing. And the amount of paperwork we have to do in that implementation is just unreal. So this is just like dreading having to do the paperwork piece of it and just sort of dealing with the interpersonal aspect of it. Redesign the EHRs to make them work for physicians rather than the other way around. That would be nice. We need a whole other presentation and talk for that one. Decrease regulation, decrease paperwork, increase kindness and care for physicians, and reclaim our identities as altruistic. Right? This whole idea of being able to see your physician, have your physician care for you, have you be prioritized by your physician, that the care is the sole focus of that, has really been compromised by all of these other things. So, I think in a nutshell, when we just sort of look at this, we had to put this, heavy job on the back of the physician, right? It just becomes a job, right? It's not perhaps the career, it's not the art and science that you really hoped that it would be when you got out of grad school. There's really just too much work being done below your skill set. And that's going to be a theme that we talk about throughout this presentation. The EHR demands of the clinician during the office visit. Again, we really know that and we feel that and experience that. So what are ways in which a well-trained team can really help with that? And that doesn't mean you have to hire a whole bunch of scribes and you have to really add a bunch of expense to your office. We're really talking about how to efficiently and effectively train your staff so that they can take over anything and everything that they can. So we have here a bullet point talking about inefficient in-basket with most work defaulting to physician. That's one and the same thing with that EHR. If you've got labs that are flowing direct to the physician, not even being screened by your MAs, and if you have, every consult note and every bit of information coming back into the physician without having your staff really support what can get sorted as normal and what can sort of be bubbled up to the level of physician, then really you've got a problem. And then the challenge of providing complex care to increasingly complex patients. And, there will always be those complex patients for sure. But now in these days of having to document everything in the EHR, have a lot of regulations around prescriptions, anything and everything that you can imagine that sort of sits around taking care of those patients, the more complex the nature of the issue, the more paperwork and the more administrative information you're basically touching as a physician. So what can we sort of do about that? I definitely think it's worth looking at just some of the percentages here because, anytime I have conversations with physicians about their EHR work, some say, look, I've got a fairly decent EHR. If you can call any EHR decent, but mine's fairly decent and I think it's okay and I'm sort of, able to work through that. Even if you think that you've got a good EHR and you're doing okay, with that, rest assured there's time that you are spending as a physician that could be better spent by your staff, or pieces of the work that could actually be designated to staff members instead of it always sitting with the physician. So think about this. During a typical office day, 27% of total time is direct face-to-face time with patients, with 49.2% of time being EHR and administrative work. Right? I know most of you would rather that it's 80-20 patient direct FaceTime with patients. You all know that, yes, you got to call in prescriptions, and yes, you have to be on the phone a bit, you have to do these things. But that is a really significant number. And so part of what we want to focus on, in talking about training and retaining staff is really, how do you push some of that stuff down to your other staff members? While you're in the exam room, 52.9% of face time is in face-to-face interactions, while 37% is focused on the EHR. There's not a whole lot you can do about that, short of having, a scribe, or short of spending the time with the patient, face-to-face time with the patient, writing out your notes, and then putting them into the system later. But at 1 to 2 hours of after-hours work at night on the EHR, that really isn't a good solution for you. So I'm sure you're aware when you are feeling burned out, your productivity goes down too, right? I like to call it sort of production paralysis, right? I find myself, if I have too many things to do, sometimes I just go into paralysis because you just don't even know where to start, right? And so, those stack of labs piling up and those notes that need to be reviewed and the things that need to be signed off on and the patients that are waiting and the fact that you're an hour behind, it really is enough to just sort of, push you into this low productive mode, not because you want to, but that's its natural consequence of being overwhelmed all of the time. And hence your engagement goes down too. Everybody's engagement goes down, right, in the organization. If you are, exhausted, burnt out, it can make you cranky. It's not fun. It's not joyous to work through, right? And so that has a knock-on effect with staff as well. And then as a consequence, we see turnover. And it's not necessarily because, the staff are so miserable, but when we're in a situation where there's just not enough attention paid to the workflow, and people that aren't trained well enough to be able to absorb the workflow, do it well, and gain good satisfaction in doing that, we look elsewhere to find that in other organizations. So a couple of conclusions here. The EHR burden on the clinicians has to be addressed. By the way, if your slides look a little funny, sometimes when we load them on technology like this on these platforms, they look a little wiggy. You will be able to download a PDF of these slides at the end of the talk, and they should look just fine in that PDF. So just in case some of you are donning glasses and trying to look a little closer at the screen, you can get a printout of this afterwards, and that will help. But certainly the EHR burden on clinicians has to be addressed. As I've touched upon, we see ways to do that as really being effectively trained care teams that are able to alleviate some of that burden, right? Care teams need robust support to care effectively for high risk and complex patients. They also need to be trained well to frankly just manage the change that comes with different workflows, right? With being, COVID ready, with then, having more patients come back into the office, with perhaps having another lockdown, right? And then things sort of moving online again. So these care teams really need good support. So how and where do they get that support? The support really needs to come from really good training and engagement. All staff need to work up to their highest skill set, not just the physician. The problem is the physician is often working at the top of their skill set and then having to do all of these things at a lower base level to your skill set, right? Do you really need to touch every lab that comes through? Do you really need to look at every piece of paper that comes through? No, you don't. Do you really need to be managing the workflow out on the floor? No, you don't. Do you need to be inputting every single thing into the EHR? No, you don't. Your staff can help with that. So really being able to identify that where you have staff in place that could be doing more, they absolutely should be doing more so that we can improve the clinician experience as well, right? So here I really wanted to say, we need to expand the quadruple aim to better incorporate what we call the missing aim, right? Of the quadruple aim, improved clinician experience is supposed to be part and parcel of that, right? Not just better outcomes for patients and lower costs for industry and improved patient experience, but improved clinician experience. And while we seem to have done a fairly good job in industry of tackling the other three, this improved clinician experience still seems to be a missing component of that, certainly based on everything that we have just talked about. So to prevent burnout, you need to build a strong medical support team. Now, for some of you, that might be information or just a statement that you feel like you sort of, know this, right? And maybe you feel stating the obvious. But when you really sort of sit with that and say, what does a strong medical support team look like? That may be an area that you haven't given any attention to. And part of the reason why you may not have given much attention to it in the past is because you're so busy doing, right? When we're really busy doing, it's hard to sort of gain that 10,000 foot view, right? And really sort of look at, well, we have these other things in place. Or if we had, the care team more effectively working on these areas of workflow and engaging with patients in these certain aspects, that really does change the game. But if you're in burnout already, you really don't have the time, let alone the capacity to be, trying to work through building and teaming and working really closely with your support teams. So let's talk a little bit about leveraging medical support staff, as I mentioned, to significantly improve efficiency. We don't just want to do it a little bit, though any little bit I'm sure would be helpful for some of you at this point. But let's talk about really sort of improving, that efficiency. And this slide definitely looks a bit wrapped, but hopefully it's still better on your screen for you. So now more than ever, right, medical assistants are really front and center in patient care. But there's a shortage of MAs in the United States, right? I will speak to that very directly. Right now we're recruiting for 5 pediatric practices across the country, and we are really, no matter where we are in the country, finding it really hard to find well-qualified, well-trained, and competent MAs. In some places in the country, we're finding no MAs. We're getting no applicants for jobs. So this really is, becoming more and more of an issue, and particularly at a time where we need them, right? It takes a while to train them. You definitely want to be able to keep and retain the MAs that you have, so you don't lose any, because it may be very hard to replace them. But you also want to be able to find and attract in those MAs who really are looking to sort of, career ladder, right? Those that are looking to develop their skills, improve their skills, and be in an organization that values that, right? That allows them to really shine in the areas that they can shine in. So again, I'm, loving data here. So let's just take a quick look at that. In 2017, and that was the last year we could actually obtain a definitive number on this, medical assistant turnover rate was 59%, right? That's really high. And the cost of turnover for an MA is approximately $14,200. How do we come up with these numbers? It's sort of a magic secret sauce. But really, these numbers are driven by things like, cost of recruitment, time spent in actually interviewing, time spent in training, etc. So it's not hard to get to that $14,200 mark. It equates to approximately 4% of the average MA's annual salary. I'll talk about salaries in a minute or two. But this really I think is very eye-opening, right? It sort of lets you know, and many of you may have felt this, by the way, empirically, right, in your own offices, that you lose an MA and it takes a long time to recruit for another one. But then, compounded by COVID-19, right? So then a lot of people went out of work. Are we getting folks back in? And that's an issue for many reasons. We have MAs that are staying out of the workplace now. In some cases, it's simply because we have so many kids being, homeschooled or schooled remotely, and parents are having to stay home, right? In other cases, we just, have a complete sort of change in the landscape of who is in what positions, and are there open positions for MAs? Are there patients back in the office? How much is being done in person, and what actually be done remotely? So we have some issues there. Now, when I say that I want you to significantly improve efficiency, that really means asking your medical assistants to take on everything that they can, not just some of what you sort of want to get off your plate, but what is it that a medical assistant can do? Certified medical assistants, anybody and everybody in your office deserves a second look to say, where is their ability, capability, and competence to either grow into that person so that they can take on more tasks, or really just be able to give them the tasks that they're already qualified to take on. So depending on where you are in the country, obviously there are different rules and regulations for medical assistants depending on your state. But as a sort of a short list, MAs really should be able to administer medications, certainly room your patients, right? Checking vitals, entering orders. But health coaching and identifying gaps in care is often where we do not have our MAs focus well, right? So just to sort of illustrate this a little further, we have one client that we were working with recently, and they have all certified MAs. Their MAs basically are the ones that greet the patient, room the patient, take the vitals, and then do it again and again and again. And I'm like, okay, well, are your MAs looking ahead to see, is little Timmy up to date with his vaccines, for example? Or are they looking to see, is this patient, do they need a glucose test? When was the last time this patient was tested for certain things? Do they need a medication refill? And it turned out really that the physicians were like, no, we need them to room the patients really fast. So, the rooming is fast so that it keeps us on task for when we have to do this stuff. And so we sort of had to take a step back and say, okay, listen to what you're saying. You're saying the faster you can get the MAs to room the patients, the faster the physician can get in the room to do all of these things that the MAs could be doing, right? So I really bring that to your attention to just underscore that there are so many things that your MAs can do. There's so many pieces of the workflow that they can take care of proactively that really helps to smooth and streamline the efficiency in your office, but can go one step further too. So health coaching, for example, if there is some information that you can really sort of, package up or parcel and just have an MA run through that with a patient. By the time you get in the room, some of those questions have already been answered, right? Identifying gaps in care, as I mentioned, if you're not having your medical assistants look ahead to see what you might need proactively when they come in, then it's always about putting out the fires, right? Then you go in, you see a patient, you see that the x-rays haven't come back, and you're calling, Sally, the MA, hey, can you track down that result? I need to find out what the x-ray was, etc. And then a bunch of time is wasted doing that. There are much more efficient and effective ways of doing this. But the caveat here is only if your staff know how, only if they're trained on how to do that. Let's talk for a minute about front office staff. Medical front office openings are expected to grow much faster than they ever have before, right? We're looking at about an 11% or higher increase, and there are currently 26,000 medical front office open positions in the U.S. Well, if we look at health, quite an aging boomer population, right? That is just one statistic right there, where you can see that there obviously are going to be more needs for an aging population, and therefore more services that need to be provided. But what we're also seeing empirically on the front lines here is that, front office staff historically are not very well paid, right? And so those jobs tend to have people that come and go in them. And there really, historically, isn't much of a career ladder for front office staff. So here we would like to just sort of draw your attention to the fact that you can retain if you train, right? You can create opportunities within a job. It doesn't need to be about progressive promotions to all kinds of other areas, though that's also a good strategy to employ if there are some options for that. You can enhance the job of any employee. You can enhance the contributions that they have to make to that simply by training them well in the areas that they know well, so that they feel like they've got full competency in that and that they're part of that support team. And then giving them opportunities to advance, as I mentioned, that can be, a great track even in a very small office. And we've seen this, happen many, many times, where you've got somebody, at the front office, they want to learn some new skills. Maybe they start going back to school, they start training as a medical assistant, and then they become an MA. So in terms of why do that, right? If we look at salaries, for an entry-level MA, we're looking at about $33,450 for that. But with experience, right, comes an increase in pay. And with the different levels comes an increase in pay. What are you really paying for? Are you just paying for the fact that somebody, has worked for an MA and not built their skill set? In some cases, yes. And that's why it's so important to have a good training program, right? Because what you might find is if there are only two candidates to choose from that are responding to your ad, and one of them is a senior MA, has plenty of experience, is used to getting paid a lot more, you're going to have to pay that salary to be able to recruit them. However, they may not actually have the skills that you would expect commensurate with that sort of salary level. So you want to make sure that you have in place a good training program, so that if you do end up with somebody that is, what I would call an expensive hire that's sort of been poorly trained, you already have a program in place to get them up to snuff really quickly, right? But then you also want to make sure that you have a good training program in place so that you can have that sort of, track for your MAs, and that you can also make sure that everybody, is really working up to the top of their experience and their game. Okay, Kayla, I'm going to take a little break and turn this over to you to talk a little bit about what training options actually look like. And I'll check back in with you and keep an eye on the questions as we go.
Awesome. Thank you so much, Suzanne. Great information, great foundation. Thanks for laying that. I'm just going to continue to build on this foundation that Suzanne's laid for us and talk a little bit more about just understanding the benefits of actually implementing a medical support staff training program. And we'll talk about using career ladders as a strategy for staff retention and career growth. So we're absolutely going to address internal training programs and opportunities. But first, let's just break down the different pathways and training options that a medical support team member has when they start seeking a start in the industry and start seeking certification. So just kind of providing a level set, and then we'll expand on that. So the first pathway is through a traditional education program at either a community college, a career college, or a trade school. These typically range anywhere between 9 and 18 months. Will include some form of clinical externship or a capstone course, and will result in a student's eligibility to sit for a national certification exam. And the second pathway is through workforce programs. And workforce programs are occupational training opportunities, usually sponsored or funded through the Department of Labor at the state and national levels. These are typically shorter programs, but they're fully integrated in the workforce, meaning that the students taking the didactic portion and getting that on-the-job experience at the same time. And the final option is an employer-based program, and this can happen in one of two ways. One, the employer develops their own training program that includes didactic content to teach the medical support member kind of that necessary material, and then they provide direct hands-on experience in the healthcare system. This is usually self-funded or through some type of internal investment or some grant money. The other way employers can develop their own training program is to develop a direct or exclusive partnership with a school. It looks similar to a workforce or apprenticeship type model, but it's usually privately funded and managed internally. So I think it's really important to note that, as you continue to develop this web of partnerships and programs, your pipeline for healthcare professionals will only get stronger the more diversified you become. So basically, the more partnerships and the more programs that you look at, the more opportunities that you have to build that strong candidate pipeline. To think about it, the average education program is only producing around 20 to 40 medical assistants or medical front office specialists or even patient care technicians in 1 year. And so these programs need you just as much as you need them. But think about, again, all of the other incredible partnership opportunities like military programs, apprenticeships, and then probably the most exciting, this organic in-house program, which we'll talk about here in just a moment. Before we get to that, I do just want to mention that if you need any assistance with connecting to schools or training programs in your area, that's certainly something that NHA can assist with. So feel free to reach out after this webinar, and we're happy to help kind of serve as the catalyst in that process. As a health organization who provides patient care and hires health professionals, again, there's two main pathways you can take to develop your own training programs. And the first aligns with many of the scenarios that we've already mentioned, in which you partner with an existing educational institution. So those schools and programs hire the instructors, they provide the classroom training. Your organization then would provide the hands-on externship portion of the program. And this really provides a great bridge from school to employment. It allows employers essentially to have the opportunity to evaluate a potential employee on the job. It's kind of a try before you buy scenario. So there's a lot of benefits to the employer. And of course, the second pathway that we're encountering and helping to develop more is a full in-house training program. And this usually works really well for healthcare employers who have nurse educators or a full team dedicated to training. So there's not as much of an upfront investment in developing those programs. Your team's really able to align the content to the systems or the practices initiatives, your scope of work, your best practices. And the ultimate goal here is to train your own medical support team and have more quality control and develop employees who are committed to the success of the organization. I think that Kelly Aiken really says it best here when she says, when the front line is better trained and has career advancement opportunities within the organization, there's a direct correlation to improved patient care and improved patient satisfaction. And I really do believe this. We just reviewed a number of different avenues of collaboration with educational partners and workforce opportunities, which we've seen lead to an increase in qualified candidate pipeline. But there's an even greater impact opportunity here in just improving the quality of your candidates and improving patient satisfaction and really impacting that bottom line. So the next thing, we'll go a little bit more in depth. And when we talk about a certification program and working at the top of your skill set that Suzanne did a great job of kind of outlining for us. We'll talk a lot more about a case study with the health system in Indiana and why we feel that an employer-based certification program is so beneficial to an organization. And the system in our study, kind of early on, created what they called a career ladder, providing career advancement for medical assistant team members if they were to become certified. So if they started out as an MA1, upon certification, they could grow to an MA2. And there's some other benchmarks of climbing up that ladder. And after years of having this so-called ladder in place, they realized that only 16 of their care team members, and they're larger, actually took advantage of that opportunity, which is really, really small. And so the system reached out to their staff and they said, hey, why aren't you doing this? Why aren't you taking advantage of this? You could get a pay raise. And their staff shared back that we don't have the ability to pay for the certification up front. Even if they're being reimbursed for it, they can't come up with that upfront cost, let alone create the time to study and have those structures that they need to really be successful. And so that health system reached out to NHA. We worked with them to develop a plan, and we partnered with them to create an embedded MA certification program. And the difference is, instead of just saying, hey, you can get a move up the ladder if you get certified, go figure out how to do it, we actually provided some structure around that. So to do that, the system provided the upfront cost for their staff members to obtain their certification. They used NHA's outline to facilitate the process and really provide, in some cases, an in-house coach to support them through this process. They also gifted them with 3 hours of on-the-clock study time each week, and sometimes that's doable and sometimes it's not. And so they first started out with a pilot of 100 team members, and within minutes of this registration start time, they had more applicants than they had seats available. To date, they've certified around 227 MAs across the entire organization. And with all of these supports in place, they were able to finish 2019 with a 99% pass rate on the CCMA exam on their first attempt. And currently they're at 100% pass rate so far here in 2020. So providing these supports were really key in actually standing their team members up for success and really helping each of their care team members to obtain a credential, to start working at the top of their license. And I think when we're considering this investment, it's really important to have some data points in mind. You're saying, okay, Kayla, that sounds fine, but show me the data around this. So before this system partnered with NHA, their MA turnover rate was in the 75th percentile. Within 1 year of starting this particular support structure, their MA turnover was at the 10th percentile. I mean, and this is very good and just practically unheard of to make this drastic of a change in a positive direction in such a short amount of time. And really, through the duration of the partnership and the program, the turnover in the MA position has consistently maintained between the 10th and 12th percentile, which again, and Suzanne pointed out the numbers before, right, of what it costs to retain an MA and what it costs to essentially go out and hire a new MA. So it's a tremendous impact to the bottom line. But in addition, the vacancies in the MA position decreased by 43%, and lower turnover rates indicate that they not only hired MAs, but they retained them by giving them a reason to stay. The MAs felt invested in, and they could see that, hey, I might not need to go from an MA to another total position, to Suzanne's point, but how do I advance within my profession, within my field? How do I take on these additional responsibilities and feel that investment from my employer? And I know it can be intimidating and often overwhelming when you're talking about developing a career ladder, but we're certainly here to help. And you'll see a simplified outline to what steps really need to happen here on your screen. So first and foremost is just identify the motive. What are your goals? Hopefully we've provided some of that today, but really think along the lines of increasing retention and increasing quality of your medical support staff and their training. Two is just putting together your baseline competencies. So we showed you the different MA levels that was reported by Wanted Analytics, and based on years of experience, you saw some great recommendations from the Indiana health system. So determine if those align with your practice or with your system. Are there additional skills or maybe micro credentials that you would want your steps to include? So, like NHA has a soft skills training for healthcare professionals and motivational interviewing training to better engage patients and learning resource on team-based care for those operating in that setting. So decide if what are those rungs on that ladder and what are those competencies that you'll put into place? The next is to outline the career ladder. The great news is if you haven't gotten started on your career ladder already, we can provide you with a sample outline that you can use as a follow-up to today's webcast. And in the design phase, will really be specific to your organization, but this is really where you get the final buy-in from the stakeholders and the ROI. So you'll want to identify the team who will be part of the education and the implementation, which is really an exciting part. You'll likely already have job descriptions in place, but once this program has been formalized, you'll really want to make sure that these job descriptions and opportunities reflect the appropriate language and are applicable to the roles that you've developed. Getting closer to implementation, you'll educate the leaders. So think practice managers, recruiters, and those types of people on this process. And they'll really be the key players in getting the buy-in from your medical support staff and just this process overall. They'll likely be fielding the initial questions. So having an FAQ or like a one-pager available that outlines this process will be really helpful. And then finally, make the formal announcement and generate excitement about this. This is such an awesome opportunity for your medical support team to really start thinking big picture about what's next for them and really give them that motivation to be committed to your organization. Another great way to do this is to assign what we call champions from within your pool to be kind of peer leaders and to ultimately kind of lead the way through this process and really help support that buy-in. So I'll show you a couple of samples here of a career ladder or some career advancement opportunities. It's really recommended that as a team member progresses through each step that they experience an increase in pay as well. We kind of talked about that earlier. So step number one is if they're uncertified, obtain a certification from an accredited certification agency. This really allows you as the employer the added benefit of, again, ensuring quality and safety in your clinics. What we found is that physician confidence in the medical support staff also increases when the staff are certified. As mentioned, you can also implement something like NHA's personability, like the soft essential skills or basic professionalism training at this as a rung in this ladder as well. Step two is expanding the candidate scope of work and really allowing these additional tasks. So you can see some examples here on the slide. There's the health coaching and NHA has the resource that can help, really expand these communication and patient engagement skills and through motivational interviewing or whatever that looks like. Step three, or kind of the third rung on the ladder, is to promote to a team lead role, or some might call this like a preceptor role. And the employee can lead team huddles as well as train other staff. This also allows MAs to help ensure that the physician is in flow and on time. Again, removing some of that workload. We saw the emoji earlier of the physician carrying that job on their back, and so it really helps distribute some of that workload. And from some of our partnered employers, we found that not only retention increases with a standardized career ladder in place, but patient satisfaction scores also tend to increase, while the burden of work for physician decreases with the adoption of things like team leads and preceptors. And so it's kind of it really just benefits across the entire organization. So no project is complete until you've sat down and really evaluated your success. And we shared some of the great success from our partner in Indiana and some of their pass rates and their participation and their ROI and retention. But we're providing you here kind of some of the sample measurable outcomes that you can track in hopes that you'll be able to see some real tangible results. And again, these slides will be available after the presentation today. We really appreciate you staying with us, and we hope this information was helpful as you develop the best way to attract and retain quality healthcare professionals. I'd also like to personally thank Suzanne Madden for her insight and partnership in this. Again, in follow-up, we will provide you with a handful of resources outlining what we discussed here today and really helping with your next steps. We'll also include our contact information, Suzanne's and mine. So if you have any questions or if you want to know about NHA and the Burden Group and our professional development for your employees, we're certainly happy to assist with anything we can there. And we really look forward to ultimately hearing about your success and helping your employees to access a better future. And with a little bit of time remaining, we're happy to answer any questions. Again, you can submit those by typing them into the Q&A box, which can be found on the right-hand side of the presentation window. And any questions we don't get to, we will follow up with you directly after the webinar. So I'd like to just take some time here just to allow anyone to type in some last-minute questions, and we'll do our best to address those. And we may just address those out loud for whatever we can here. So I'll see if we can get to some of those.
There's a couple of questions that have come in, Kayla. There's one just asking about job descriptions for MA 2 and 3. Is there a resource that perhaps we can direct folks to for that one?
We can, yes. I have that question tagged here. We do have some sample resources that we can provide on what those descriptions look like, how to make those distinguishing marks from an MA1 to an MA2, and making sure that your staff sees, again, that progression. I think that's really, really key. Thanks for that question. And I have that here, and I will follow up with you directly for that. Danielle from OSS, I see you said, what if the interested staff members have been working as maybe a medical secretary or receptionist? Are they also eligible to pursue the CCMA certification? Absolutely. As Suzanne kind of pointed out that ladder earlier, we work with many employers that are saying maybe a progression, if you're working in the front office side of things, your progression could be to a front office specialist, or they could progress from the front office to the back office. Sometimes it's easier to find someone for your front office than it is the back office. Sometimes it is, sometimes it isn't. So absolutely. There are we just recommend obviously some hands-on type training. That's where maybe an apprenticeship type model can come in, or an in-house training can come in. But yes, they can certainly utilize that ladder to create those things. And yes, there will be a recording of this presentation. I'm trying to see what I'm missing here. Anything else from you, Suzanne?
Just scanning a couple more that came in. Without a dedicated office manager, how to allocate tasks and track productivity and efficiency. EMR makes it hard to track who works hard and who slacks. So yeah, if I am interpreting Kevin's question here correctly, it basically is asking, if there's somebody sort of overseeing all of this all of the time, how do we make sure that the staff can really be working productively? Part of this really does speak to that training, right? You also want your teams to be able to sort of hold each one accountable. So knowing when you have a training program in place and your staff knowing that they've been put through that, you'll find that your staff will actually keep themselves on task too, right? Nobody wants to be the one that's picking up all of the slack. The key thing here is to make sure that the tasks do get allocated in terms of, hey, team, this is what you're taking care of. And then at the end of the day, if certain things not been taken care of, to give that feedback, but to basically make sure that your staff feels empowered to then discuss, okay, who's on base for what. That can be a way to really sort of effectively manage that if you don't have an ops manager to do it for you.
Great question. Great question. I had another one of what jobs are candidates getting with the CEHRS, which is Certified Electronic Health Record Specialist. That is, a lot of front office positions. That can also serve as a kind of what we call a stackable credential for even a medical assistant. So, as we're talking about working at the top of your skill set, sometimes employers look for what's different from you about the other pool of MA candidates. So the electronic health records certification, I think, is a great stackable certification for any front office or, quite frankly, clinical professional, knowing that there's a lot of people that have their hands in the electronic health records. It really just depends on if the student or the candidate want to be more on the administrative or the clinical side of things.
Okay.
I'm going to try to read through some other questions here. Thank you. These are wonderful questions. And anything that we didn't get to today, we will certainly address these with you directly. Medical Economics has been kind enough to provide us with a download of those, and we do have your information, so we will respond with you with an answer. Again, we really appreciate everyone's participation and engagement today. Thank you again to Suzanne. We hope you have a great day. Suzanne, do you have any closing remarks before we end our time today?
No, I think it was a really great conversation, and thank you everybody for joining us today. Kayla, thank you for an excellent presentation. I always get to learn things too, so I really appreciated the information that you presented today as well.
Excellent. Thank you. And likewise, Suzanne. Thank you all so much. Have a wonderful day. Thank you for your time.